Good morning, friends. Today we'll be discussing about ischemic aspects, surgical aspects of ischemic heart disease, that is coronary artery disease. So, before starting, I would like to thank Chandana Shri Ma'am for sharing the wonderful notes with us, and the link of the notes is given in the description. You can download it from there. So, let's get started. Ischemic heart disease, coronary heart disease. So, coronary circulation is Coronary circulation is with the help of epicardial conductance vessels and along with intramyocardial perforator vessels, which are the resistance vessels. So we have the right coronary, the branch of right coronary as right atrial branch, right posterior descending, and right marginal artery. In the left, we have left main coronary, left circumflex artery. Then we have left marginal and left anterior descending. Then we have some smaller branches. Important point is branch to SA node is through the right atrial branch. Then right coronary artery is from the right aortic sinus, and the left coronary artery is from the right is from the anterior aortic sinus, and the left is from the posterior aortic sinus. These aortic sinus are just above the aortic valve, arise from the ostia above the aortic valve. So in three vessel disease, most commonly it is LAD, RCA and circumflex branches. If it is involvement of left main coronary, left main stem disease, it has worse prognosis without surgery. So inaccessible at its origin, because left main coronary is inaccessible at its origin. So grafts are anastomosed to its branch, that is LAD. So LAD most frequently diseased vessel, most frequently bypassed during CABG, that is coronary artery bypass graft. Then LAD most frequently diseased, if it is affected, then more than 50% of the left ventricular mass and interventricular septum is affected. Then we will see the coronary dominance, based on which arteries gives off during the posterior descending, gives branch to the posterior descending artery. So most of the time it is right coronary artery, so it is right dominance. Venous drainage is by three systems, that is coronary sinus and its tributaries, which drain into the left ventricle, which carry 85% of the coronary venous blood flow. Then is the anterior right ventricular veins, which drain into the right atrium, and Thebetian veins, which right into the right atrium and right ventricle. And the coronary sinus afterwards at the end open into the right atrium. So overall the blood goes to the right atrium. Now we'll see the pathophysiology a little bit. The risk factors for coronary artery disease will be dyslipidemia, smoking, hypertension, diabetes, and it affects the epicardial conductance vessels more than the intramyocardial vessels. Pathogenesis being lipid deposition resulting in plaques, which could be concentric and eccentric being more common. Plaque formation, large eccentric soft lipid core, thin fibrous cap with inflammation and plaque neovascularization and vessel remodeling. All these lead to are high risk features for plaque rupture and resulting in thrombosis. So clinical features could be chest pain radiating to the left shoulder, and tachycardia, palpitation, diphoriasis. These could be clinical manifestation, and which will present as a stable angina or acute coronary syndrome. That could be unstable angina, NSTEMI, non-ST elevation MI, or ST elevation MI, STEMI. So how will we evaluate ischemic heart disease? By non-invasive method, the first and the foremost being the resting 12 lead ECG, then the troponins and the cardiac isoenzymes CKMB, then the treadmill test or exercise tolerance test along with pharmacological testing. Then we have echo, which will assess ejection fraction, left ventricular ejection fraction, regional wall motion abnormality, valvular defects, LV aneurysm, LV thrombus. We can combine it with technetium 99 scan, that is a radionuclide scan. It will help us in myocardial perfusion detection. It will be done with the help of thallium 210. Then we'll go for cardiac MRI with gadolinium, evaluation of the ischemic burden, cardiac CT, which will give us details about the proximal coronary artery disease, degree of coronary artery calcification, that is the calcium score. Then we come to the invasive method, that is the coronary angiography, which is the gold standard. We'll come to know the extent, whether it is one vessel, double or triple vessel disease, severity, percent of luminal reduction, more than 70% is significant, and 50% for left main and proximal LAD is significant. Location of the disease, distal coronaries, quality, size and collaterals. Important point which we have to understand is the functional flow reserve, which gives additional data about physiological effects of the stenosis. It passes a sensor through the guide wire into the vessels and injects adenosine to induce hyperemia. So if the functional flow reserve is less than 0.75, then there is ischemic lesion. Then we have intravascular ultrasound, hybrid imaging in the form of CT angio along with PET or SPECT CT. So we'll go for coronary artery revascularization, that is with help of coronary artery bypass graft or percutaneous coronary intervention, that is PCI. So what are the indication for CABG in stable IHD? Stable, we have to understand it is stable IHD. So it is left main vessel disease, that is the gold standard for CABG. 3 vessel disease with proximal LAD involvement, 2 vessel disease with proximal LAD involvement in diabetes, completeness of the revascularization is better with CABG. Then sudden cardiac death survivor with post-MI arrhythmia. So in the 3 vessel disease with proximal LAD involvement and the sudden cardiac death, CABG is equivalent to PCI. In rest of the cases, CABG is better than PCI since it shows completeness of revascularization. And PCI may be preferred if angio shows low risk of PCI complication and increased surgical risk. So revascularization, that is why PCI is superseded emergency CABG, that is in unstable cases we do not do CABG nowadays. We go for PCI, that is percutaneous coronary intervention, that is the we'll see ahead. And CABG is not usually performed in isolation, it is combined with other treatment for specific complication like refractory post-infarction angina, papillary muscle rupture with MR, or infarction with VSD, septal rupture, that is which will lead to acute failure of PCI. All these may lead to acute failure of our intervention. So now the percutaneous intervention, first we'll go for the percutaneous access with help of femoral artery or the radial artery puncture through the Seldinger's technique. We'll insert the guide wire, then the sheath introducer, the guiding catheter advancing to the coronary artery, anticoagulation, angiogram done by the injecting dye, then tip of the catheter is advanced beyond the blockage, balloon is inflated and pulled back, then we place a stent which could be a bare metal stent or a drug eluting stent which is deployed. The drug eluting stent may have drugs like sirolimus or paclitaxel. So primary PCI is done nowadays in acute coronary syndrome in the emergency basis. Now coronary artery bypass grafting. So what are the choice of conduit we have? That is the internal thoracic artery, the mammary artery, which has the highest patency rate at 5 years and 10 years, 98% and 5 years and 90% and 10 years. Most commonly used is the lima, that is left internal thoracic artery. Proximally, we the left attached to the subclavian vessel, and distally it is anastomosed to the target coronary vessel. Generally, it is used to bypass the LAD, the anterior circulation. Greater saphenous vein, which has 90% patency at 1 year and 70% at 10 year. It could be, harvest technique could be open or endoscopic to ensure minimal manipulation during the harvest. Radial artery, after confirming satisfactory ulnar collateral with the help of Allen's test, harvested by again open and endoscopic technique, better patency than GSV. Then rarely we use SSV, gastroepiploic artery or cephalic vein. So right coronary artery is commonly bypassed using right GSV or right radial artery. It can be made into composite graft and can be sewn sequentially. So here is the diagram showing left subclavian giving rise to lima, and then it is being used to anastomose with the LAD, which is blocked, and rima, which is not long enough to reach the desired site. Then we'll go for the approaches. We have 4 approaches here. That is the classical CABG with hypothermic fibrillatory arrest, on pump beating heart bypass, and the off pump CABG. So here classical CABG will go for sternotomy, then conduit evaluation and harvest, then cardiopulmonary balloon, then myocardial arrest, that is cardioplegia, identification of the distal vessel and anastomosis, restoration of the myocardial electromechanical activity, that is reversal of the cardioplegia, proximal anastomosis, intra-aortic balloon pump, pacing with inotropes, weaning from cardiopulmonary bypass, reversing anticoagulation, hemostasis and closure. In CABG with hypothermic fibrillatory arrest, we'll go for same things initially, then after cardiopulmonary bypass we'll go for cooling the patient at 28 degrees Celsius, will resulting in the fibrillatory arrest. So there is no cardioplegia and no aortic cross clamping. It is beneficial when there is calcified aorta, because cross clamping may cause stroke. Rest will be same, anastomosis, weaning off from the bypass, reverse anticoagulation, hemostasis and closure. On pump beating heart bypass is same, where up to cardiopulmonary bypass there will be no attempts at cardioplegia or arrest. Heart continues to beat. We try to anastomose, we know from the bypass, and then up to closure. Done in very low ejection fraction patients who have suffered recent MI, and it can be coupled with intra-aortic balloon pump. So the last is off pump CABG, where we start with sternotomy, harvest the graft. There is no cardiopulmonary bypass, no cardioplegia, anastomosis is performed on the beating heart. We use myocardial stabilization device from the Medtronics to keep the operative area relatively immobile and stable. Like the apical suction devices, we anastomose, reverse anticoagulation at a very low dose, hemostasis and closure. It avoids the adverse consequences of the cardiopulmonary bypass. So here in the last one of pump CABG, we do not use cardiopulmonary bypass. So now we come to the novel techniques, that is the mid-cab, that is the minimal invasive direct coronary artery bypass, where it is extension of off-pump CABG, where left anterior mini thoracotomy, mobilization of lima, direct in situ anastomosis to LAD and diagonal branches. It is used only for the single vessel disease mainly. Then we have TACAB, TECAB, total endoscopic coronary artery bypass, that is done with the help of robotic assistance. CABG, hybrid coronary revascularization, that is PCI with mid-cab or TCAB. Then we have transmyocardial laser revascularization with help of CO2 holmium yttrium alnium garnet laser to create multiple transmural channel, that is holes which are 1 mm wide. It acts as a conduit for direct myocardial perfusion by the ventricular blood and result in angiogenesis. Now we see the complication of CABG, that is bleeding, early post-op cardiac tamponade. Arrhythmia can be treated with drugs, cardioversion and pacing. Ventricular dysfunction due to ischemia, reperfusion injury. Treatment will be through oxygenation, inotropes, correcting acid-base disorder, pacing and intra-aortic balloon pump. Stroke due to embolism or wound infection. So these are some of the complication of CABG. Hope we have gone through and understood the topic of ischemic heart disease surgical aspects well. Thank you for listening. Keep studying, keep growing, and see you in next video.